Hello everyone, today we'll talk about principles behind lung auscultation. The role of lung auscultation is to help you figure out differentials and help you aid in diagnosis. Both positive and negative findings are important. While you're auscultating, make diagnostic connections with regard to your patient's symptoms. Let's try to figure out where these sounds come from and how to understand them. The airway sounds are generated when there is a turbulence in the airway, which is present in the trachea and upper airways. These constitute your bronchial and vesicular sounds and any other transmitted sounds. In distal airways, you make two types of sound. First is your whistling sound caused by the standing waves, which you hear as wheezing or rhonchi, and popping open of your airways if there are secretions present. These are heard as crackles. So the breath sounds are sounds of turbulence generated in the upper airways. These are transmitted down into your larger airways to your smaller airways unimpeded. Some of this sound is now absorbed by alveoli and scattered by airways, and some of it is absorbed by skin and soft tissues, and rest of it is auscultated through your stethoscope. Since turbulence depends on flow, most of this sound is generated during early inspiration and early expiration. These are loud and high-pitched sound. If you observe closely, there is a pause between inspiration and expiration. So there is a gap of sound between inspiration and expiration. As the sound reaches from your bronchi to the alveoli, there is a lot of scattering with changes in phase and speed. This results in gradual disappearance of the pause between inspiration and expiration and removal of high-pitched component from the sound. This results in the vesicular breath sounds that you hear. The sound that was generated in the upper airways is also called bronchial breath sounds. You can hear what bronchial breath sounds by auscultating your trachea. The sound that is transmitted to your stethoscope by absorption through normal lungs, they are soft and low-pitched sounds. These are called vesicular breath sounds. If you have a consolidation of the lung, there are less number of air-liquid interfaces, so there is less scattering, phase change, and absorption. So the upper airway sound can now go unimpeded through the lungs and can be heard through the stethoscope. This is abnormal, and this is called bronchial breath sounds. So you'll hear bronchial breath sounds when there is minimal air-liquid interface on the way to your stethoscope. So for example, a consolidated lung with an open airways, for example pneumonia, will result in bronchial breath sounds. Similarly, if you have lung collapse with an open airways, such as happens in pleural effusion, you should be able to hear the bronchial breath sounds at the apex of pleural effusion, where the lung is collapsed. If you have minimal lung tissue between airway and skin, such as in cavities or in bronchiectasis, you can sometimes hear bronchial breath sounds. If you got an obstruction in the airway, there will be no sound that will be conducted to the lungs, and you will hear dimness or no breath sounds. One of the very important tests is echophony, which is E to A conversion. In normal airways, some of the sound from E is absorbed by the liquid interface. However, the lungs are mostly air, so the sound can go unimpeded through the lungs. In consolidated lung, since there is more liquid in the lungs, more high frequency is absorbed, and if you remove the high frequency from the sound E, you get an A. Echophony is heard in consolidation. This is a very useful technique to find consolidative areas in obese patients in whom the breath sounds are more difficult to hear. Adventitious sounds consist of crackles and wheezing. These can cover up your bronchial and vesicular breath sounds. Crackles are heard due to popping open of lower airways if there is a secretion or mucus present. Reals are very coarse crackles. Fine crackles are usually seen in fibrosis, and these are usually late inspiratory. Wheezing and rhonchi, however, are heard during expiratory phase. If you remember, during inspiration, the intrathoracic airways are larger, and during expiration, the intrathoracic airways are much more narrowed, and If these are narrowed further because of bronchoconstriction, airway edema, mucosal hypertrophy, or from secretions, you can generate musical sounds, and these are called wheezing and rhonchi. Wheezes are high pitch, more than 400 Hz, and rhonchi are low pitched. However, it's very difficult to differentiate frequency of the breath sounds. All you have to remember is wheezing or rhonchi are indicative of obstructive disease. Secretions from upper airways can flutter during inspiration and expiration, and these sounds can be conducted through the lung fields, and you might be able to hear crackles, rails, and conducted sound, but these are present in both inspiration and expiration. So secretions can result in multiple sounds like crackles, rhonchi, diminished sounds, and conducted sound. To differentiate this from other etiologies, ask your patient to cough and see if the quality of these sounds change. Because of cough, you will be able to mobilize some of these secretions, so you will hear different sounds after coughing. Diminished breath sounds are easy to understand. One of the reasons why you will hear diminished breath if you do not generate any turbulence in upper airways, and this can be seen when the flow is very slow. These are seen in patients who are tiring out and in patients with muscle weakness. If you've got blockages in the transmission of the sound to the lungs, for example in mucus plugging, the breath sounds will be diminished. If there's a blockage in transmission outside the lungs, for example pneumothorax, pleural effusion, and obesity, you will hear diminished breath sounds or no breath sounds. Other sound that you hear is stridor. If you've got a fixed extrathoracic or intrathoracic obstruction, you will hear stridor in both inspiration and expiration. To understand variable obstruction, you have to understand how the airway diameter changes during inspiration and expiration. When you inspire, the extrathoracic airways become narrower, while the intrathoracic airways become more wider. And this is because the negative pressure during inspiration is generated in the pleura, which stretches the intrathoracic airways, while the negative pressure inside the trachea in the extrathoracic part would tend to narrow the diameter. So a variable extrathoracic obstruction will cause inspiratory stridor. During expiration, the opposite happens. During expiration, since the pleural pressure is more positive, the airways inside the thorax are much more narrower, while the extrathoracic airways are much more wider because of positive pressure inside them. So, a variable intrathoracic obstruction will have expiratory stridor. When you auscultate patient with pleural effusion, you should be able to hear normal vesicular breath sounds in non-affected areas. At the apex of your pleural effusion, there is a collapsed lung with open airways, so you might be able to hear bronchial breath sounds in this area and egophony. Below this area, there will be diminished or no breath sounds. In consolidated lungs, there will be secretions in the airways, and since the lungs are consolidated, you should be able to hear bronchial breath sounds and egophony. You can also hear crackles and rhonchi depending on the amount of secretions. Other important thing when you are ausculting is to focus on what you are looking for. For example, if you already have a patient with pneumonia, looking for crackles is not going to aid you further. What you are really looking for is if the secretions are blocking the airways and if the patient needs help removing them. So it is better to auscultate their bases and see if you can hear breath sounds in those areas. Since pneumonia patient would have good bronchial breath sounds at bases, if you hear diminished breath sounds, this is worrisome as it means that your patient is having difficult time in managing secretions. If you have a patient with sudden hypoxemia, try to think about what you are looking for during auscultation. There are few things that cause sudden hypoxemia. Common among them is a pneumothorax, mucus plugging, flash pulmonary edema, COPD exacerbation, acute pulmonary embolism, or acute upper way obstruction. In patients with pneumothorax and mucus plugging, you will hear no breath sounds. In flash pulmonary edema, you will hear crackles. In asthma or COPD exacerbation, you will hear wheezing or diminished breath sounds. In acute pulmonary embolism, you will hear normal vesicular breath sounds. In acute upper airway obstruction, you will be hearing stridor. Make sure that you auscultate the bases of the lungs, as most of the lung pathologies occur here. One of the things that you have to remember, there is no correlation between the degree of wheezing and degree of obstruction. So comments like wheezing is much worse today, so my patient is getting worse, or wheezing is much better and my patient is getting better, do not really make a logical conclusion. There is some evidence that the pitch and the duration of wheezing during expiration are possibly related to the degree of obstruction, but it's never the amplitude. In fact, the wheezing will diminish if your obstruction increases, if your obstruction decreases, or your patient is tiring out because there is decreasing flow. If you really want to look at if your patient is getting better or worse, look at more objective parameters like capnography, peak minus plateau pressure, etc. There are many nuances to auscultation. However, you just need to understand basic sounds which will give you an idea about diagnosis. So in summary, listen for bronchial breath sounds and egophony. If you hear these, that means there is a very good conduction, more than normal, and this would be seen in consolidated lungs. This can also be seen in patients with cavitary lesion and bronchiectasis. If you hear crackles, that means there are airways opening and closing, and you are possibly dealing with secretions or fluid in alveoli or bronchioles. If you hear wheezing or rhonchi, that means you have airway narrowing because of bronchoconstriction, airway edema, or because of secretions. Diminished air sounds will be heard if there is slowing of the airflow, if you have lung collapse with closed airways, for example mucus plugging, any obstruction to the sound conduction like pleural effusion, pneumothorax, or obesity. Always make sure that you auscultate bases of the lungs where most of the pathology happens, and ask your patient to cough to see if the quality of breath sounds change, and that would give you an idea if you're dealing with secretions. Thank you.